Smoking is a huge problem in the United States and throughout the world because it contributes to tremendous morbidity and mortality. For example, in the United States, somewhere around 440,000 deaths every year are directly attributable to smoking. And about 20% of Americans, even in 2009, continue to smoke. And we know that physician interventions can actually help diminish that number. CS2day includes 9 organizations working together as a group to improve the rate of tobacco cessation in the United States. The way to do that is by focusing on clinician education. The organizations really are complementary.
It's really proof of the old adage that the whole is greater than the sum of its parts. Each of the 9 organizations contributes its unique set of knowledge and skills to the overall initiative, and the project benefits from the perspective and contributions of each of the participating organizations.
Organizations have the common goal, but with different skills and talents to reach a level of sophistication and outcome that had never been even contemplated before in the world of continuing education.
The greatest success for the collaborative is really the collaborative itself. It is the first time that people have come together from all of these different areas of health education, continuing education, pharmacy, medicine, psychiatry, all of these different disciplines coming together to achieve a common goal. Our goal is to assist all clinicians with tobacco cessation strategies. Through group process, we came to consensus. We developed a very successful way to hold each other accountable for the forward progress of the entire group. And through this group process, we were able to develop different efficiencies. And this was a process that I personally had never been involved with before. But I would label this as a huge success for the partnership as well as for continuing education in general.
Starting from a core curriculum, we melded or brought in the needs assessment data that we had obtained, brought in key faculty members, and said, okay, let's start with the science from the guideline. The U.S. Public Health Service Clinical Guideline Update hinges upon the concept of what are called the 5 A's. The 5 A's are as follows: to ask, to advise, to assess, to assist, and to arrange. That's the cornerstone of the guidelines. From those 5 A's, we derive competencies. They, in turn, were the cornerstone for the development of educational activities.
The 5 A's of the curriculum is a way of framing a whole understanding of the continuum of getting your patients to quit smoking.
This is a time where clinical outcomes are critically important. We realized that we had to measure the impact of our educational interventions. We wanted to see, were learners learning information, were learners changing their behaviors, and we reached that goal. The idea here is that if we have shared outcomes, we can be much more powerful with regards to really determining the impact of this educational partnership. I'd like to describe to you a conceptual model around different educational interventions. Some are based at the clinician level. In other words, the target is literally one learner. Some are based on a group of learners. And others are based upon system changes. And across the array of the interventions in CS2day, we hit all of those. Learners have told us how effective the educational interventions have been. We will reach over 20,000 clinicians via certified educational activities. Over 400 credits of education are available, and 10 types of credit have been utilized.
The evaluation component of the CS2day initiative has truly been the most extensive evaluation component of any tobacco education project that I've ever done. From the formative level to the outcome level, the whole spectrum of measurement has been considered. Without effective evaluation, we don't know if what we're doing is working. So I think the level of commitment of this entire group has been truly extraordinary.
The other day, I had a middle-aged man who smoked for many years, and he came back in for follow-up, and my nurse had written down he was a non-smoker. And I thought she must have made a mistake. I said, my nurse says you don't smoke anymore. He goes, that's right. I said, well, how'd you quit? Well, you told me it was bad for me, and nobody really talked to me about it before. So I quit. Could have knocked me over.
Over 80 tools are part of the toolkit that is available on the CS2day website to help clinicians improve tobacco cessation rates across the country. CS2day comprises 4 performance improvement projects. These 4 will allow us to assess and improve performance improvement opportunities. We'll be able to share best practice, and we're going to be able to learn from each other on how to do things better in the future.
The performance improvement has changed the way everybody's dealing with the patients. It's really been a fun challenge, and watching the staff grow has really been, I think, exciting, as well as a success with our patients. Over the past 2 years or year and a half that we've been involved with this project, my success rate, or our success rate, has increased tremendously. I probably have more patients that have quit smoking in the last year and a half than I did my whole 18 years prior to that, which really tells us that there's a different way to do things in medicine, and a team approach is the right way to do it.
Medicine in the modern era is a team-based system. Medical assistants, nurses, pharmacists, physicians, advanced practice nurses, physician assistants, everybody together, the patient's family, the environment. It really is a whole system that takes care of people, and so the registry gives people tools to make an impact. So the idea of team-based delivery of care is really, really critical to thinking about this.
A registry is a tool that is used generally in physician offices to assess their current level of performance and to identify opportunities for improvement. All of the participants working on the CS2day initiative use the same standardized clinical measures endorsed by the National Quality Forum. Significant improvement has been noted in some of those measures as time has gone on.
Sometimes education is about improving the knowledge of one person. Sometimes it's giving people a system tool so that literally the way that they care for people changes. That's really novel. That's where we need to go. System changes are really going to be the key going forward. The next generation of CS2day is going to be focusing on smoking and mental health, people who are using both nicotine and alcohol, patients who have comorbid conditions, which makes it more difficult to use some of the techniques. The inpatient population is an area that needs to be focused on. And also there are groups who are light smokers. We're going to continue to focus on the 5 A's. We're also going to be expanding our collaboration in our processes with quit lines. We're going to be focusing on motivational interviewing, and an emerging area in research around tobacco cessation is the use of combination therapy. The idea that perhaps using more than one medication might be the best way to achieve higher tobacco cessation rates.
Smoking and the issue of mental health is one of those topics that I don't think is talked about very often, but it's huge. This addiction to smoking and nicotine is probably the hardest addiction that folks with chronic mental illness have to give up. People with mental health histories smoke much more. They smoke 50% of the cigarettes in this country. The comorbidities that often go along with smoking, you'll see alcohol. There's a huge connection with alcohol. People who smoke often drink. It's often a trigger.
I do think we need to take it to the next step. I think that this group needs to move forward, and we need to take what we've learned, take our skill sets, take our competencies, and apply them in new ways. We've talked a lot about place-based initiatives, which I do believe is kind of the next generation for CS2day. Working with cities, working with towns, working with states. A key element of any tobacco control initiative really must be educating clinicians, equipping them with the best strategies, evidence-based strategies for helping their patients quit.
The model did work, which has resulted in better care for patients.
It's been extremely gratifying to be involved in this program. It's been a real honor. And my hope is that we can continue this program and expand it.
This is a fresh approach. It's an innovation. It really is. In the process, just purely the process is an innovation. And there's nothing else like it out there. And I think that this approach holds the most promise of anything that's going on currently in tobacco control.
Changing clinician behavior is the focus of CS Today, because tobacco use is far and away the leading killer in the United States.